Hi, everyone. Thank you so much for joining us. This is Inga Hansen, editor of MedEsthetics magazine. We're going to go ahead and get started. If you have any questions during the webinar, you can type them into the question box on the right-hand side of your screen, and we'll answer them at the end of the presentation. Today, we're going to be talking about the pathophysiological processes that cause adult acne and discuss new methods, including holistic and natural treatments, to help you more completely clear your patients. Our presenter is dermatologist Carl Thornfeldt. Dr. Thornfeldt has been in private practice for 35 years and has been researching abnormalities of the skin barrier, cutaneous inflammation, drug delivery, herbs, and disease therapies for more than 20 years. He holds 22 U.S. patents, has published more than 40 scientific articles, and is the founder and CEO of Epiciences, maker of the Epionce skincare line. Welcome, Dr. Thornfeldt.
Thank you, Inga, and it's great having you all on board this afternoon. So the reason we're going to be talking about understanding adult acne is because there are changes that have occurred in the science as far as the foundation of what's driving acne, and that then adjusts our strategies for therapy. So the most important is how much acne will affect the population. Recent studies have shown that 45% of women between age 21 and 30 suffer from acne, 26% of 30-somethings, and 12% of 40-somethings suffer from acne. Now, most of the patients will come in to see you and I, and they will consider that their skin is a problem skin. But when we actually examine them, we see that it's not just congested, not just excess oily, but we actually see inflammatory and non-inflammatory acne lesions. Now, in the adult acne, the lesions are more usually located on the lower half of the face and on the neck. And adult acne is defined as someone over 22 years of age. So what's the impact on patients? It's just been recently we've now been able to understand the quality of life impact of acne, that it's no different than a person suffering from diabetes mellitus, asthma, seizures, or back pain. In other words, it really has a very adverse effect on quality of life. So what are the psychological problems? One, decreased self-esteem is afflicted by 71% with this problem. 64% have embarrassment. 43% claim that they have difficulty finding dates. 39% claim that they are shy because of the acne. Another 31% say they're nerdy. And it is also stressful and creates problems in making friends, according to 24% of the patients, lonely and introverted in 23% of the patients, and challenges at school in 21% of the patients. So absolutely has an impact on overall quality of life. But then the problem is when you actually question these adult patients, 80% do not feel that the current regimen works. And in other words, they feel that it's a treatment failure because their expectations are complete clearing and complete disease control, inducing long-term remission. Well, we know because of the underlying drivers that complete remission is possible, but we can't say that we actually cure it. So let's look at some of the misconceptions. First of all is that an oily surface equals acne. That's not the case at all. It's the abnormal oil that's trapped down below that actually plays a role. The surface oil is the body trying to reverse the inflammatory component. But when you actually look at the causes of treatment failure, the number one cause is lack of compliance. In other words, they're not using the medicines the way they should. So, for example, of the prescriptions written for acne, 50% are filled within a day, which is good. 90% are filled within 2 weeks. But if we look at benzoyl peroxide use, 80% of the patients will use it in the first week, but that falls to 30% by week 6. It's now been shown that in younger adults, teens and 20-somethings, that they feel that if they had weekly reminders and every other week office visits, that they would actually respond the best to treatment. And so that's what happens in the clinical studies, why we can have such great results with various prescription products, because they're being seen frequently and evaluated frequently. So let's look at the physiology. Well, you're all familiar with the different grades. Grade 1 is less than 10 lesions, goes up to grade 4, which has the multiple, so 2 or more deep nodules, cysts, scarring with severe inflammation. And so let's look at what actually drives it. We used to think it was actually the gland, the sebaceous gland, behaving abnormally in response to hormones, but now we actually know that the primary driver is in the infundibulum, the area just before the oil gland hits the surface of the epidermis. Now, there's still epidermis going down into that area, so there's a thinned epithelium there, but it's now been shown that people with acne, there's a direct correlation with the amount of ceramide, one of the three key barrier oils in that area, and how well functioning that barrier is going down into the pore. It's now been shown that in acne, actually the disruption of that barrier down going into the pore is actually the major driver here. And so that will then trigger inflammation, and the inflammation then produces a reactive sebaceous gland hyperplasia. Well, part of that characterization is not only increasing size, but also increased production of the oil. But because that gland is also under control of hormones and various nerve stimuli, as well as environmental factors, things like humidity and temperature, the oil that's produced in response to the inflammation is an abnormal oil. And so it's sticky, it's high in wax esters, which is pro-inflammatory, and it clogs the pores, and then results in the pustule and what we see as open and closed comedones. So the key differentiating factor now is that we understand that inflammation is the major driver. And that's why stress can play a role in acne, because it affects blood flow. So, as I mentioned, disrupted follicular infundibulum is the key driver. Then it produces a subclinical inflammation and then activates a retention hyperkeratosis. In other words, the lining of that follicular infundibulum thickens in attempt to repair that compromised barrier. And then the sebaceous gland abnormalities occur, and then you'll get the inflammation response to furthering the inflammation response from the hypertrophy. In addition, the androgens contribute to that sebaceous gland hyperplasia. But again, androgens are stress hormones. They're directly related to the amount of inflammation that occurs locally as well as systemically. That's when times of high stress or say start an athletic season, you will see the acne flare. It's because those androgen levels go up, and not only does it affect systemic, but it will also have an effect on the peripheral superficial glands as well. So the microcomedo is formed by that sticky pro-inflammatory wax ester, and then that produces the open and closed comedones. So then the microbial problem is really secondary. Now, naturally, because of the pH of the skin, there is a large amount of Propionibacterium acnes in the microbiome. In other words, the amount of microbes on the surface of the skin. And there's a lot there. I mean, there's 10 times more microbial DNA on the surface than there is keratinocyte DNA. But in this setting, with the inflammation upsetting the balance and inducing inflammation, you then get also P. acnes proliferation. And now we know that particularly in adult acne, Malassezia furfur yeast, also known as Pittosporum orbicularis, proliferates. And we now know that 68% of adult women is actually driven by this yeast. We know that the parasite Demodex follicularum, which we thought used to be a rare player in acne, has been shown now to infect and proliferate as the intrafollicular pH rises. And so that becomes more of a issue as well in driving the inflammation. But then the other thing that happens is because of that increased inflammation, and particularly of the humoral immune system, there is a marked increase in allergic content sensitization that occurs to the yeast, to the parasite, and the bacteria. And so you're really dealing with, and this is, in my opinion, one of the main reasons acne is difficult to control once you get into grade 2 or above, is because you're dealing with allergic sensitization as well as infectious inflammation. Now, the pro-inflammatory lipase that results from the body's response to, and from these microbes, that actually creates larger, more inflamed lesions, and then those will rupture, and then that's result in the cysts and the nodules. Okay, 30% though of the patients, because the disruption of the microbiome, because of the change in the pH, and because of the excess inflammation, become opportunistically infected. Why? The humoral immune system has increased activity, but the cellular immune system that fights off infection is diminished. So then you're particularly susceptible to Staphylococcus epidermidis and aureus, to gram-negative bacteria such as Proteus, Pseudomonas, Klebsiella, and also to Candida albicans yeast as well. And now a recent study just a few months ago actually showed that there's a direct correlation of grade 4, so cystic acne, is associated with increased incidence of prostate cancer as the patients mature. So reasons to treat that have required changes in therapy are to not only treat the new pathophysiology, to treat the complementing infections that occur, but also prevent comorbidities. Now, you're all quite familiar with the in-clinic treatments, such as deep cleansing facials and extractions, the microdermabrasion with or without radiofrequency, a variety of chemical peels, various light therapies, including the photopneumatic broad beam light with suction therapy, different laser lights, infrared light, diode lasers, IPL, CO2 slush. They're well known for those of us that practice, although in my case, I don't use the blue light because since it penetrates so superficially, it doesn't really get down to the deep glands, which are the acne glands are down usually 1.5 to 2.5 millimeters below the surface, whereas the blue light only penetrates the top 0.4 of a millimeter, and so I like to get deeper to have a greater effect down in there. All right, now the common topical ingredients, many of you are familiar with these individual lesions, the individual treatments, and the ones that are the most effective are ones that have combination therapies. In other words, we know that for the topical antibiotics, benzoyl peroxide is not only antimicrobial against P. acnes, but a variety of other microbes, but it also prevents microbial resistance. Clindamycin is a potent anti-inflammatory as well as antimicrobial, and these other agents that are listed there have a combination of anti-inflammatory and antimicrobial effect. Those are listed under the topical antibiotics. And then it's on the right side of the chart. On the left side of the chart, we have those that are keratolytic, but these are also anti-inflammatory, such as lactobionic acid, the retinoids, including tretinoin, retinol, and adapalene, and tazarotene. So, and then in the middle of the chart, we have the non-keratolytics, but these are also anti-inflammatory and antimicrobial, like tea tree oil. The problem with tea tree oil, though, it's a photosensitizer, so that tea tree oil products should not be used on sun-exposed areas because the phototoxicity will occur deep enough that will actually aggravate the acne for later on effect. You'll get early benefit, but it activates more chronic inflammation, so you have persistency of the acne later. There's other agents such as the zinc pyrrolidone with seaweed extract, phytosignosine alone, which is one of the 11 ceramides, but is also the ceramide that's antimicrobial. Has benefit in and of itself. And then one of the most interesting and most recent is spearmint, where studies have shown that it's potent anti-yeast, antibacteria, and anti-inflammatory. Now, one of the agents that's often used in adult acne where there's suspected to be a rosacea component is metronidazole. But several studies have shown that metronidazole, even though it has some mild anti-inflammatory effect and antioxidant effect, doesn't have therapeutic benefit in true acne vulgaris. So if you look at the topical prescriptions, so for example, clindamycin plus benzoyl peroxide, that has been shown to be significantly superior to either agent alone. And it's also been shown to be superior to topical retinoids in reducing total number of inflammatory lesions. And that's because it's anti-inflammatory, it's broad-spectrum antimicrobial, but the anti-inflammatory effect of the clindamycin reduces the irritation of the benzoyl peroxide, so compliance is much better because patients can tolerate it well. And when you actually look at the clinical studies with this combination, they've shown that it's equal to 100 milligrams of minocycline. So the most recent study of clindamycin plus benzoyl peroxide showed that it had a 53% reduction of inflammatory lesions, whereas 100 milligrams of minocycline at 10 weeks had a 52% reduction. Okay, whereas clindamycin itself was at 32% and benzoyl peroxide was at 37%. Now, the retinoids are equal to the clindamycin benzoyl peroxide in reducing comedones. There was no statistical difference between the two, although the retinoids had a numerical superiority. But the problem is the retinoids have some photosensitivity. And because it's now known that this is an inflammatory-driven process, anything that will increase inflammation can aggravate the underlying disease. And that's one of the problems with benzoyl peroxide. And that's why I use it in combination with other anti-inflammatories such as clindamycin. Excuse me. Okay, so the oral supplements or vitamin A. The dose that's effective for over-the-counter is 50 to 150,000 units a day. Sorry about this. We've had some allergy issues here lately, and that's thrown my voice off a bit intermittently. So anyway, but the problem with that dose is that you have a risk of headache and photosensitivity and dry skin, but it does have benefit. Zinc picolinate is the zinc that has the least amount of GI distress, so I find that more effective than the other types of zincs and works quite quickly and anti-inflammatory, but it also helps improve the healing, so it reduces the scarring. Niacinamide or nicotinamide at 500 milligrams daily to TID has been shown to be beneficial, but it also has anti-inflammatory effect by improving the skin barrier in particularly skin of color, but it also shrinks down the follicle to some degree. And it's recently been reported that it actually reduces the incidence of cutaneous malignancy by 23%, taking it for 3 years, because the chronic inflammation from acne is associated with higher incidence of other types of, is expected to be higher incidence of other cutaneous malignancies, and so niacinamide helps prevent that. So we use a lot of that in our practice. Now, there are other combinations using zinc, copper, niacinamide, folic acid, or using alpha tocopherol and chromium and a carotenoid with vitamin C and zinc. So all these in a clinical trial have been shown to be beneficial in treating acne. These other supplements that have documented activity is a selenium tocopherol succinate combo, lactoferrin, combination of niacinamide and azelaic acid orally actually produce an 88% reduction of inflammatory lesions. Keep in mind that's substantially better than minocycline. And vitamin D has been shown to be helpful, particularly when acne flares in the wintertime. And we often see flaring between Thanksgiving and New Year's as they move into and start developing the vitamin D deficiency. The problem with vitamin D, though, if you get above 5,000 IUs a day, it can activate atrial fibrillation. So you do have to be cautious, and I recommend 2,000 IUs a day for standard therapy. I mentioned organic spearmint tea. 1 cup twice a day has been shown to be equal to minocycline after using it twice a day. Recent data that came out of the United Kingdom, so very helpful. What about the oral prescriptions? Well, we know there's a large number of oral prescriptions. Just last April of 2017, it was conclusively proven that ampicillin and amoxicillin had anti-inflammatory effect. Prior to that, we would see that work in acne in a rare patient who had a gram-negative folliculitis that was secondary to long-term use of minocycline, doxycycline, tetracycline, or clindamycin. But now that's been documented to have anti-inflammatory effect. The ketoconazole and fluconazole have shown to be highly effective in eradicating the Malassezia furfur. But that dosing, it's a once-a-week dosing for 12 to 18 weeks, but shown to be highly effective in that. Sulfasalazine, also approved for inflammatory bowel disease, does have a potent anti-inflammatory, better effect than regular sulfonamides actually, but also allows an impact on the on the bacterial agents as well. Has no effect on the yeast, but is effective as a antibacterial. So these are the workhorse ones. As you notice, erythromycin's not on here because such a high incidence of resistance to it. Rifampin we'll use in small doses, anywhere from 300 to 600 milligrams daily for 15 to 30 days to potentiate the effect of the minocycline or tetracycline or sulfonamides, but should not be used as a solitary agent in the acne patients. I do warn the patients that it can have an impact on making the urine turn an orange color and may affect some staining of contact lenses. So for acne grades 3 and 4 that has at least 25 lesions, they do require usual multiple medications in addition to the topical regimen. Now, because I'm a referral-only dermatologist, I do see a lot of patients who have been treated with a lot of the standard therapy for months to years, so I do a lot of cultures. I do find that grade 2, most of those patients need just oral supplements in addition to the prescription topicals or the non-prescription topicals that are highly effective, which I'll talk about later. But occasionally I have to use an oral prescription with the grade 2 patients. It's also important to face the reality of the oral contraceptives. There are some oral contraceptives that reduce androgenic activity, and in clinical studies, 55% of the acne patients will clear after 6 months of use. So it's slow onset, and it's only 55%, but of course for that 55% it's very effective. Those reduced androgen ones include Yasmin, Trifazal, Orthotricycline, Demulin, and Desigen. So not all birth control pills will have a positive effect on acne. Just like when you're with pregnancy, about 1/3 will get better, 1/3 get worse, and 1/3 there's no difference. Now, there is an oral contraceptive antibiotic controversy that I want to address. It's been known that tetracycline combined with ampicillin or amoxicillin, it inhibits enterohepatic recycling of estrogens, thus reducing their activity. And so if you combine either tetracycline, ampicillin, or amoxicillin with the estrogen, that would decrease the recycling effect, and that would then reduce the activity of the estrogen to make that more clear. If you add these antibiotics to rifampin or use these antibiotics alone, you will find that there's a decrease in the gut microbiome. And the gut microbiome is really important for normal estrogen metabolism. So if you decrease that gut microbiome, then you would expect reduced efficacy by estrogens. The only thing is that's only theory, because even though that's happened in animal studies, no studies in the last decade, despite multiple review articles, have shown no clinical effect. So the incidence of pregnancy has not been increased when an antibiotic, one of the cyclines, amoxicillins, or ampicillin or rifampin was added to the birth control pill. Now, to be conservative, and because those studies are done on hundreds of patients, and yet there's millions of patients out there, I do recommend that patient take a probiotic each daily, 5 to 10 billion colonies a day, so they regenerate the gut bacteria, and use a second form of contraception if they're not interested in pregnancy. Now, keep in mind, besides the active inflammatory lesions and blackheads and whiteheads, open and closed comedones, there are also concerns that patients have. One is hyperpigmentation that will occur after the larger, deeper symptomatic bumps and pustules, and that's because of the prolonged inflammation produces a post-inflammatory hyperpigmentation. This is especially a problem in areas where they keep recurring in the same site. They're also concerned about the scars, ice pick, boxcar, hypertrophic, sunken, and papular scars, as well as uneven color and texture of the skin, and deep milia or persistent closed comedones and cysts. So your patient has concerns about all these, so when you're addressing the acne, it's important to keep that in mind. And for compliance issues, focus on the acne, but let them know that you understand that there are these other issues, and you're going to create a regimen for them that you can add on to work on these at a later time as we get control of the active inflammation. Now, one of the problems that I commonly see, of course, I practice in Idaho, so high desert, is a patient will come in with their skin red, pinks, or scaly because they're using drying topical products. That actually causes fissuring or cracking of the skin surface. That actually incites the inflammation. So I'll have a patient coming in using an over-the-counter, for example, a 5% benzoyl peroxide or 10% benzoyl peroxide multiple times during the day to soak up the oil, and they're red and inflamed, but they're getting all the deep inflammatory nodules consistent with cystic acne. So you want to warn them that you don't want intense surface drying because otherwise it will incite inflammation. So what's our approach? Okay, so we don't want to trigger or drive inflammation while we're addressing all the patient's concerns, not only of the acute lesions, but also the other concerns, because at the end of the day, our goal here is to improve their quality of life. And if we're creating a lot of pain and anxiety with the treatment program or discomfort so the patients won't use it, that's defeating the purpose of what we're trying to accomplish. So as I said, number one concern is patients' quality of life. So to improve compliance, we want to use cosmetically acceptable products. We want to use cost-effective products. We want to simplify the regimen, but keep in mind that it's a multifactorial disease, so there's not one single product that will work in all these patients, and they have to understand that, and so that each product that you add to the regimen has a specific use. And I tell the patients this is what it's going to be used for and why they need it. So for Epionce products, we have the Purifying Wash or Lytic Gel Cleanser for the mainstream cleanser. We have a Purifying Toner. We have 4 different Lytic products and their differences in potency. We have a Purifying Spot Gel to treat acute onset lesions, which we'll talk about the therapeutic data later. The Renewal Light Facial Lotion, which works on addressing the inflammation, which many adult, particularly women, just using this product alone oftentimes has a great impact in clearing acne. And then, of course, using sunscreen because the light is photosensitizing and increases inflammation. So our regimen for acne with Epionce products, we have the dry sensitive skin regimen, which includes the wash or cleansing, gentle foaming cleanser, the light Lytic TX and the Purifying Spot Gel, then the Renewal facial cream or lotion at night, and then the sunscreen. For normal or combination, we have them use the same cleanser. Then we have them use the Lytic TX at night and the Lytic Plus they can use after their first tube to see how they tolerate with that. And then the Purifying Spot Gel. And then the facial lotion and the sunscreen. In those patients, I usually use the facial light for that. In the combination to oily skin, we'll use the Renewal Facial Light Lotion, the sunscreen, the Lytic Plus TX or the Lytic Sport, and the Purifying Spot Gel. in those patients, once we get into combination skin, that's where the toners are particularly effective for extra oil control. And then for perimenopausal women, the problem is that they will have a mixture of areas on their face. And so we'll not only have them use the 2 cleansers I mentioned earlier, but also the Lytic Plus. I start off once a day to see how they tolerate it, and then use it twice a day. And they'll use the Purifying Spot Gel, and then the Renewal facial light lotion or facial lotion on those, depending on the part of the face that they're using it on. But keep in mind, the sunscreen is critical for the protecting and preventing, to keep out that inflammation. And now we know that airborne pollution is a major driver as well, and that's why it's even more important to use the Renew and Fortify products to keep that skin barrier intact, and yet not clog the pores. But keeping that barrier intact helps prevent the pro-inflammatory nature of the micron and the nano-sized soot and gas that actually are pro-inflammatory and drive acne as well. So those aspects are all really important and an area that often is overlooked. So our purifying wash is an over-the-counter monograph for acne. It uses salicylic acid, 0.6%. Again, we want to maintain barrier function, but we want comedolitic effects. We want to clean the pores, and we want to reduce the microbes on the surface, as well as having anti-inflammatory effect. We also have white willow bark, marshmallow, spearmint, menthol, and date fruit in there. It turns out this product also is effective for treatment of psoriasis and dandruff and keratosis pilaris as well. We have 5 botanical ingredients in there: willow bark, date, spearmint, marshmallow, and menthol. They all have in common anti-inflammatory effect, broad spectrum antimicrobial effect. But they have different active ingredients so that the differences of the microbes on the surface and in the pore won't develop resistance to the therapy. In other words, we do not want tachyphylaxis to develop, which can if you have an agent focused in one aspect. How do we know that? My chairman, Dr. Dick Stoughton, in UC San Diego, did a lot of the original work in tachyphylaxis, and one of the problems we found was with the clindamycin alone, was the development of tachyphylaxis. Now, a couple of these agents also do have some analgesic effect to reduce the discomfort, because a certain number of these inflammatory lesions may have symptoms ranging from itching or pain with them. Our Lytic Gel Cleanser is a great refreshing antimicrobial cleanser. Adults particularly like this product. It can be used in a whole variety of dermatitis conditions ranging from acne, dermatitis, psoriasis, keratosis pilaris. So in other words, follicular and surface excess scaling and abnormal amount of scale that builds up. It can also be used as a non-smudging shampoo for patients with seborrheic dermatitis or who have acne in their scalp. And they can use their regular conditioners after that. It has received the award 3 times in a row as a cleanser you can really feel working by New Beauty. So that was 2016, 17, and 18. The Purifying Toner removes the dirt, oil, and makeup. It's formulated to reduce surface shine and control excess oil, reduce the surface bacteria. It helps spot treat as well. And so it helps in acne, but it's also effective for people who are sensitive to getting various kinds of skin, yeast and fungus infections, as well as keratosis pilaris in the pores of atopics. Our Lytic products were designed to use all 4 active ingredients that are static against gram-negative and gram-positive bacteria, as well as yeast. They're anti-inflammatory, they're anti-parasitic. And these Lytic products will accelerate cell turnover, smooth skin texture, and they're a very potent chemolytic effect. We figured out how to produce synergistic activity using salicylic acid, azelaic acid, zinc pyrethan, and menthol in these actives. So it does have potent anti-inflammatory effect as well, and reduces scarring and dyspigmentation. Surprisingly, in adult women with acne, it also reduced fine lines as well. These also have willow bark extract, which provides a salicin, which is a aldehyde of the salicylic acid, and this allows a slower penetration, less irritation, but improved activity. Meadowfoam extract, avocado extract, rosa canina, and then the phytosphygnosine is also included in these lytics. So they were designed to be used for people who had sensitive skin, who were atopic, or who had reacted to retinoids, benzoyl peroxide, or AHAs in the past. And so for those sensitive skin patients, which afflicts 30 to 50% of adult women, depending on the race, I will start with the light lytic and then increase the lytic strength every 6 to 8 weeks, depending on how they're tolerating it. Light lytic has a factor of 1 in strength. Lytic TX is 5, Lytic Sport is 7, and Lytic Plus is 8 when we look globally at all the different factors that are associated with the function of those. The lytic treatments are also important as a adjunct to the renewals because they do, with the chemolytic effect, allow deeper penetration of the renewals, and so that's why the combination of those two is shown to be twice as effective as Renova combined with its lactic acid moisturizer. So twice as effective in dermal rejuvenation using that combination. For optimum benefit, you should put the lytic on, wait 5 to 7 minutes before applying the renewal, and that was worked out in vivo. Now, how does this compare to standard therapies? If we look at Epionce lytic, compare it with 10% benzoyl peroxide, so moderate acne vulgaris in adult women in a double-blind, split-face, prospective controlled clinical trial, where we use Lytic Lite in the morning and Lytic TX. Now, we expect Lytic Sport and Lytic Plus to be more potent than this, but even at 6 days, we saw that the Lytic TX combo reduced lesional erythema, size, and elevation by 41 to 47.8% within 6 days, so nearly highly statistically superior, whereas benzoyl peroxide reduced it 20.0 to 27.2%. The Lytic TX was highly statistically superior in all of these lesional parameters. Then at 12 weeks, we showed that there was a 51.2% decrease compared to baseline, whereas benzoyl peroxide decreased by 39.7% compared to baseline. Now, because of the small study, there was not a statistical significance between these two treatments, although there was a profound numerical activity, and when we looked at the activity that there was clear benefit. Now, if we look at these numbers compared to what's been published with minocycline and with spearmint tea, they were all, and with benzoyl peroxide, clindamycin prescription, they were all equal at about 51% at 12 weeks. Now, 72% of the patients preferred the lytic program over the benzoyl peroxide. We also had texture improved, nearly double over benzoyl peroxide, and no lytic patient found that their face was drier or scalier, yet nearly half of the benzoyl peroxide patients complained of that, and as we showed earlier, that's a huge impact as far as affecting compliance. So the key is these patients have to use the product on a regular basis. Now, as I mentioned, we also found in this study that perioral and periocular fine wrinkles were reduced by 48.3% at 8 weeks. Here's a patient who had failed 2 courses of isotretinoin and using our topical therapy plus our Epionce chemical peels produced this benefit 6 months after treatment. Now, our newest product is our Purifying Spot Gel, and this fits the over-the-counter monograph for acne, and yet will show you that it was equal to a prescription product. So the active ingredients were colloidal sulfur, okay, and it's been known for literally millennia. Sulfur was first used to treat skin diseases. It was talked about in the Bible. It has chemolytic effect, antimicrobial, and anti-inflammatory effect. But by making it colloidal, with extracting it and suspending it in acacia, we're able to make the granules smaller, smoother, so they have improved penetration and also improved anti-inflammatory effect as well. As people know in the dermatology arena, resorcinol has been around for decades for use in chemical peels. The problem was it had some abnormalities that would induce, namely hyperpigmentation and skin of color. Well, when the monoacetate form came out recently, we found that using that form, we don't see the hyperpigmentation that occurs. And again, we improve the chemolytic effect and broaden the antimicrobial effect. So using those two in older known, long-term known ingredients, but combining them and formulating them in cutting-edge ways, we are able to take advantage of the benefits and completely mitigate the adverse reactions. So we did combine them in this product with azelaic acid, zinc pyrethin, coconut oil, spearmint oil, menthol, sunflower oil, and safflower oil, all of which have anti-inflammatory effect, and paprika oil, which also has a counter-irritant analgesic effect as well. And so we found that this combination is more potent than either sulfur or resorcinol functionality. Now, there are some products on the market that have been out for years that have both sulfur and resorcinol, but none of them have this potentiated sulfur, and none are using resorcinol monoacetate. So we do have this uniqueness about this technology, and that's why we had the confidence to do the clinical trial against the clindamycin benzoyl peroxide product. Now, azelaic acid, as you know, or may or not have not known, that I held all the original patents for that for treatment of a variety of treatment diseases, including rosacea and drug delivery. And it's been shown to be as effective as hydroquinone in treating hyperpigmentation, has been shown to be as effective as Retin-A in reversing fine lines, but it has also been shown as a drug delivery agent, so we can improve activity. As you know, it's prescription for treatment of rosacea at the higher concentrations. Zinc pyrethin is known for its anti-inflammatory, antimicrobial, and chemolytic effect, and is an over-the-counter FDA monograph drug for treatment of dandruff. Incidentally, the azelaic acid is on the generally recognized as safe list at lower concentrations. The two botanical ingredients are coconut oil, which is very broad spectrum anti-inflammatory, the highest natural source of lauric acid, which is anti-Staph aureus. It's also the highest natural source for the 8-carbon atom caprylic acid and capric acid, which keep the yeast on the skin microbiome under control. It's effectively used to treat psoriasis and dermatitis in traditional medicine around the world. And it also prevents the product from becoming dry, from drying the surface of the skin, activating inflammation, as does the spearmint oil. And we've already talked about the spearmint oil. We also have rosemary extract in there, and that's important because it's the natural highest source of quercetin, so it's potent in stimulating repair. Again, it prevents hyperpigmentation from occurring. But rosemary extract is also the highest natural source for carnosine, which has been shown to protect the DNA of keratinocytes and fibroblasts. And ursolic acid has been shown to realign elastic fibers, which reduces scarring. Because when you look at scar, you see jumbled up elastin and collagen fibers. This helps realign the fibers. Again, it was impossible to deliver until we discovered that we could deliver it with combining it with azelaic acid. Sunflower and safflower oil have been known for years to have high concentrations of linoleic acid, which is a key barrier oil, also important for retaining moisture, recovering the skin barrier, but it has in and of itself antimicrobial, antioxidant, anti-inflammatory pathways. But one of the most important aspects, the fraction we use also is a PPAR agonist. So this is peroxisome proliferating activating receptor, and that's important for activating epidermal differentiation to heal that follicle. So not only do we get resolution of the inflammatory disease, but we should reduce recurrences at specific sites because of that improved healing of the damaged follicle. We have some of the other botanical ingredients that I mentioned earlier, such as menthol and paprika, which are anti-inflammatory, and then rice bran also, which has various benefits for skin, including antimicrobial effects and antioxidant effects. So to prove whether this actually works, we did a clinical trial with clindamycin 1.2% and 5% benzoyl peroxide. Had 11 patients because we wanted to see if it really worked. The adage has been if you don't see statistically significant improvement in 12-patient clinical trial, or now it's even been shown down to 8, you're not going to have an impact in the marketplace. We measured erythema elevation and diameter as well as assessed tolerability. And we found that at using our PSG at day 1, we had a statistically significant superiority in decrease of inflammation by 21.3%, and compared to the benzoyl peroxide, which only reduced it by 5.2%, which is not statistically significantly superior. And then at day 6, we had a 71.3% decrease in erythema, which was statistically significant, and benzoyl peroxide at a 65.5%. In elevation of the lesion, same aspect. We had statistical significance at day 1. Benzoyl peroxide did not. And at day 6, the elevation was 84.8% decrease with PSG compared to 59.0% for benzoyl peroxide. So certainly numerical superiority. Tolerability, there wasn't any difference in reducing the amount of overall erythema. Both of them reduced overall erythema by 72% at the end of the 6-day trial. But the fact that there was superiority indicates that we felt we were a better agent than the benzoyl peroxide. Here's before and afters. Before and afters at individual lesions. You can see how they resorb with this therapy. Renewal Light Facial Lotion has technology that's anti-inflammatory against all 7 cutaneous inflammation pathways, as well as repairs all 5 pathways involved with barrier repair. So it's really important in its treatment to prevent further destruction. The Daily Shield tinted sunscreen is non-comedogenic, even though it has a physical blocker with the zinc oxide and titanium dioxide. It is tinted. It is antioxidant, fortified, very water-resistant, anti-inflammatory, but is very potent in blocking sun and pollution induction of inflammation. Again, like all of our other Epionce products, the RAPT is negative, so it doesn't activate irritation and inflammation. And our Ultra Shield does have the phthalates in it and zinc oxide, and it's lightweight. It does not have any tinting in it, but very water resistant. Again, non-comedogenic, non-sensitizing, and has anti-inflammatory, antioxidant, barrier repairing activity as well. So those are the Epionce products. So hopefully today you learned a lot about the new technologies, but also about the new strategies for treatment of acne. Thank you so much for listening, and now it's open for questions.
Thank you so much, Dr. Thornfeldt. First, I did want to let everyone know that this will be up on the MedEsthetics YouTube channel and our website. I know there are some people that were asking how they could get copies of the slides, so you will be able to go and review them. And we have a lot of questions that have come in. If we're not able to get to all of them, then we will follow up with you after the webinar. One of the questions that came in is, are these products safe, the spot treatment and the other products, for patients who are pregnant or lactating?
Yeah, these actually are, because the active components in there have never been reported to produce any pregnancy or lactating issues, and the two actives have been shown to be safe in pregnancy. Now, we can't claim that we can say that it's perfectly safe in pregnancy, because this formulation has not undergone the 3-year clinical trial. But because all the ingredients have never been reported to produce problems, it's not expected that there would have any impact. And keep in mind, you're only using the spot product for anywhere from 1 to 6 days on a particular lesion. We recommend applying it 3 times a day right on the spot. So we have a real confidence in the safety aspect there. You know, if we had positive RIPT test, which is for irritancy and sensitization, that would be another concern, but those were both negative.
Great. And we had 2 questions that had to do with facials, and one was just, do you recommend professional facials during acne treatment? And if so, can Epionce products be used for in-office facials?
Yes, they can. We have a refresh peel to combine with facials, which has been shown to be very effective in acne patients, which has been shown to be also safe even in immunosuppressed patients, and has a modulating effect. I think that the facials are important and have become more important now that all this data came out this summer about compliance that was presented at the Summer American Academy of Dermatology. And so regularly seeing patients with these chronic conditions, it is important to reinforce that they're using the take-home products and that they are being seen to get the best benefit of the treatment regimen.
And do you recommend extractions, and are there any certain types of breakouts or blemishes that should be avoided during the extractions?
Okay, 2 things. I do recommend extractions, but keep in mind they have a limitation. So first of all, the extraction process is called acne surgery. It is covered by medical insurance, usually a treatment once a month for that. So we do those in the office. And the only thing is that it's been shown that if you're not using any topical therapy, within 13 days, the comedo comes back. So you've got to use topical therapy in addition to that. Also, I find that the extractions are most effective where we can get them out, where we only need to do it once a month or every 6 weeks or so, when we combine it with a superficial chemical peel, even with the refresh chemical peel, which is allowed to be used by any esthetician in any state in the country without a physician being on site. As far as the inflammatory lesions, when they have particularly a pustule that's symptomatic, I will lance it with a number 11 blade just to open it, and then you pull the lesion apart. You don't squeeze, because you can actually produce a rare embolus or a clot of microbes and drive it deep, particularly in that central third of the face. So you always want to pull it apart with those inflammatory type of lesions that have become full-blown pustules. But a lot of times for relief of pain, that works well. Now, the spot treatment, of course, is when you start doing that right away, that should prevent any lesions to getting to that particular point in the evolution of the disease. Any other questions? Inga, are you still there?
Hello? Yes.
Okay. Okay.
I'm sorry. I think I hit mute. I'm sorry. Someone's asking about the different supplements you were recommending ingredients. Are there any brands out there that you recommend?
That's a good point because the FDA went into Walgreens 3 years ago, and 77% of the supplements sold in Walgreens, 86 brands, they found that 77% had a decrease by 50% of the number of active ingredients that they claimed on the bottle, or less than 50% of the amounts that they said on the bottle. 2 of the brands had 0 active ingredients at all. And then even a recent study was done, this was published a few months ago, where they took cosmetics that were claiming that they had retinol in them, and they found that 40% had 0 detectable retinol at all. In other words, because in the cosmetic arena and the supplement arena there's no federal control, there's a lot of fraud going on. So the way I handle the supplements, I sell the supplements in my practice that I see that there's a clinical trial proving that that particular supplement works in a specific disease. If you look at the double-blind studies, and that's what I focus on, is double-blind studies. When you look at that in the method, they will say where they got this, what the source of, where they got that particular product, and so then we will bring in that brand. So the brands that I carry are ones that actually have been studied in the clinic, so I know it works. I will say that the majority of our brands come from pure encapsulations, and any kind of skincare professional can sell those products in their offices. And then we have a number of products from NOW. But there's a variety of brands out there, and you do have to be careful. So when you're going to carry a brand, ask them what their data is for stability and efficacy.
Great.
In other words, does it work? So.
Mm-hmm. And another one of our attendees was asking if these products can be used as effectively on the chest and back as on the face.
Yes, they can. Keep in mind, the follicles on the chest and back are larger than on the face, and they're deeper. That's why it starts later on in the course of onset of the disease. But they don't have the density. So consequently, those areas are very risky for developing irritation reactions. So that's one reason why we designed these products, is because I wanted something that we could get people in the habit of using every day in the chest and back, because we found that the topical retinoids, they could usually only use 2 or 3 times a week, and then their compliance dropped off substantially because they forget to do it. Okay, so our products can be used on the face and on the chest and back, as well as the face. But I also tell the patients that because the lesions are deeper, they will take longer to respond. So generally, it takes about 10 days for them to clear.
And we had a question about if a client comes in, they have acne but also very dry skin, does that change what's going on in terms of the physiology? Is it strictly a microbial problem they're having, or what should you learn from that?
What that means is that they are getting inflammation driven by skin barrier damage, and that they have high concentrations of microbes because they've been unable to fight that off. So it's the same physiology, it's just an exaggerated level. So you really have to focus on the inflammation and on the barrier repair.
Great. And unfortunately, we are out of time. So if there are any questions that you still have or that we didn't get to, we will follow up and make sure we get you an answer. But thank you so much, everyone, for attending. And thank you so much, Dr. Thornfeldt. This has been really interesting.
Well, thank you all. I appreciate it. Thanks for your help, Inga. Bye-bye.
Bye-bye.